Hello and welcome. I'm Dr. Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington, and the founder and president of GRACE, the global resource for advancing cancer education. I'm very happy to be joined today for our program on immunotherapies in lung cancer by Dr. Ben Creelan from the H. Lee Moffitt Cancer Center in Tampa, and also Dr. Julie Brahmer from the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University in Baltimore. Thanks so much, and I also want to thank Longevity Foundation for partnering on this program with GRACE, and so many other programs have also been supported by Longevity as well. We're going to start by just talking about what I'd consider to be the newest aspect of immunotherapies and a class of agents that have really gained a lot of traction and interest in the last few years, and that is immune checkpoint inhibitors. So perhaps we can just start with a little level setting by having you, Julie, talk a bit about the basic concept of how they work.
Well, there's various different ways that your body controls the immune system, and one way that it helps control the response of your immune system is through checkpoint pathways. But we know that besides it normally preventing autoimmune disease or an overreaction to infection, tumors can actually co-opt these pathways and use it to shield themselves from the immune system. So the thought is, by blocking these pathways, we can now break down that shield and unleash the immune system against your cancer.
Okay, great. So what kind of responses are we seeing with these agents in terms of how common are they, the magnitude of responses, and how long they're lasting? Ben?
I think this is some of the most exciting stuff we've seen in oncology in the past 10 years as far as responses go. We're talking about perhaps 20% of patients, roughly, across a spectrum of 4 different PD-1 or PD-L1 inhibitors. And these responses aren't just the transient responses we've sometimes seen with the tyrosine kinase inhibitors, not just the transient responses we've seen with chemotherapy, but some durable, long-lasting responses that have gone for, in some cases, years.
So you'd mentioned PD-1 and PD-L1. What's the difference between them, and any sense of whether there is a difference in how they work or the population in which they work?
Well, I think in general, we think blocking this pathway 2 different ways might be slightly different, but in general, we get the same results. And it's nice to see both types of antibodies, a PD-1 antibody that blocks the receptor on the T cell, as well as a PD-L1 antibody that we think blocks the ligand that is expressed on a tumor cell and other cells. By blocking that, we still see consistent activity in lung cancer either way. There may be some slight nuances in response or potentially toxicity, but I think in general we don't know enough about how these antibodies truly work in our lung cancer population as a whole.
So you'd mentioned the response rate's about 20% in the various trials. Any sense of who that 20% is? Is there a biomarker that's readily available to predict which patients are going to be the big beneficiaries or not?
Well, to start with, a lot of companies, Merck, MedImmune now, and Genentech, have incorporated biomarkers into their clinical trials program. And the first biomarker that's really being looked at is called immunohistochemistry. What's that? It's basically where you just take a slide of the tumor and stain it to see if the PD-1 protein, PD-L1 protein is present on the actual tumor. In their data sets, that seems to correlate strongly with response, but there's a sizable proportion of patients that are PD-L1 negative, and they still have some responses there. So it's not a perfect biomarker, and it's still in development.
So it's not readily available for someone to just ask, can I have my tumor tested for PD-L1?
Right.
These are typically on a clinical trial.
The other issue is that with immunohistochemistry, there's differences in how one lab does it versus another, and that has not been standardized in any way, right?
Correct.
Now, the work you'd done, which is with the BMS drug, nivolumab, actually did not require PD-L1 expression. Have you gone back and looked at PD-L1 in some or all of these patients to see whether that teases apart differences between the big beneficiaries or not?
We have in various different ways. We did present some of the data at World Lung, Dr. Antonio did, and in that study it didn't seem that PD-L1 positivity correlated with response. However, there's an issue about that study was done and used archival tissue, like tissue that was taken at the time of your diagnosis. But most of the patients had been on various different treatments before they went on to the PD-L1 or PD-1 antibody. So we think potentially, since that did not seem to correlate, if we had biopsied the patients right when they went on, maybe we would have seen a correlation or not. So I think there's a lot of issues and questions about when is the best time to biopsy to see if your tumor expresses PD-L1 or not. And again, we also don't know how does PD-L1 positivity on your tumor affect your prognosis. That means how long would you do, or how would you do on chemotherapy and other therapies, and potentially that might have an effect as well. And again, I think we're trying to learn all of that as we're doing these studies.
So you'd really done some of the earliest work with these drugs, the nivolumab trial. And how long are some of these patients responding? Do we have a sense of the median duration of response, or are many of the patients who responded a couple of years ago still ongoing and we just don't know?
Both.
Okay.
So the median duration of response with nivolumab is 74 weeks, so it's just over a year. However, we all have those patients that even a year off of treatment, they're still here and doing well and their tumor is under control. I don't think we can say that we can cure them yet with this type of therapy, but certainly long-term disease control is definitely a possibility.
And you'd mentioned that some of these patients were off of therapy for a period of time. So do you keep these patients just on ongoing therapy, or is there a reason to stop it because of side effects, or just you plan to give a fixed period and then stop?
Well, we don't know what the optimal duration of treatment is. We do know that, or at least we think, we make immune memory so that your immune system can remember how to attack the tumor. And so that's why we think we're seeing patients who stop treatment, which either, depending on the trial, is either a year of treatment or 2 years of treatment, their immune system can still continue to control the cancer for a long period of time, and we just don't know what's the longest. Right now, we do have a patient with kidney cancer and a patient with colon cancer that have now been off of treatment for 5 years, and their disease has not come back yet.
Remarkable.
Yes.
So let's talk about tolerability a bit more. Ideally, we'd love to have a treatment that's remarkably effective and non-toxic. That's not quite how it's been. Could you talk a bit about the kind of side effects you've seen, or how common it is? Is this predominantly minimally toxic, or just differently toxic than conventional chemotherapy or things like EGFR inhibitors?
I would certainly say that from my limited experience, the patients who are on these drugs seem to be enjoying their lives more than people on active chemotherapy. That being said, the side effects can be unpredictable, meaning that you have to have a heightened suspicion to look for these things and to ask about them. For example, a lot of the side effects are autoimmune toxicities, which can happen 4 weeks, 8 weeks, months after you begin the actual drug.
What's your experience been, or what are the more feared side effects that we might see?
Well, the typical side effect would be fatigue, rash, sometimes diarrhea. Most of the time, those sort of side effects are very easily controlled, either by just symptomatic measures or potentially either topical steroids or oral steroids. The most feared ones, I guess, in our experience is really pneumonitis or inflammation of the lung, or hepatitis, inflammation of the liver. But again, those significant side effects are quite rare. But you do have to have an index of suspicion. The same with diarrhea. It can develop into a more extreme colitis where you're having diarrhea all the time, and so we do have to be aware that very early treatment with steroids is very important, and stopping of the drug. So it's not without side effects. So.
One of the other potentially confusing issues is the concept of pseudo-progression, which we haven't really had to deal with, at least as far as we know, in conventional chemotherapy or the targeted therapies we've used thus far. Can you just talk about what pseudo-progression is and what it might mean in terms of our actual practice with these drugs?
Yeah, so pseudo-progression probably embodies two different concepts or two different phenomena. One is where there's an infiltrative T cells that attack the tumor, causing swelling on the CT scan or inflammation on the CT scan, which seems like an enlargement, and formally that might meet criteria for progression. And so we go and rebiopsy these patients or actually remove their cancers. All we see is just infiltrative lymphocytes, no tumor cells left. Very exciting.
So it's an immune response
right.
that mimics progression of disease.
Right. However, there's another phenomenon where, and this is a little bit less established, where the monoclonal antibody may take some time to actually kick in or work. And so the tumors may continue to grow initially, and then that response somehow kicks in and a delayed response is seen.
Now, what about new nodules sometimes occurring? Because sometimes it seems like you'll actually get a new nodule where there wasn't one before, and yet with further follow-up there's actually shrinkage of everything. How could that potentially represent pseudo-progression?
The same sort of thing. In an area of tumor that is just microscopic now becomes macroscopic because T cell infiltrates, or again, the tumor takes a while to respond to the lymphocytes attacking it. So again, we can see quote-unquote new lesions. They're probably not new. They probably were there the whole time. We just couldn't see them on scans.
Mm-hmm. What about the timing of the response? You alluded to the potential for a delayed effect. How often do you see, what's the timeline for the benefit? Is it most typical to see that response within a few weeks, both in terms of clinically how the patient feels and how the scan looks, or do you sometimes see it come on months after you start them?
It can be both. About 50% of the time, at least in most of the studies, it seems that the response occurs by 8 or 9 weeks. But then that means 50% of the patients don't respond after that. So it may take a while to see the response. And so we've seen responses occur, even 6 months down the road. So I think the key thing is to remember, if you're clinically stable and your symptoms are under control and you're not having any side effects from the treatment, it's worth after that first scan, if your disease is not responding or your disease is increasing in size, then staying on the treatment for another period of time. And if at that point, then at the next scan, 6 to 9 weeks down the road, if your disease is responding or stable, then that's significant. However, if you are not clinically stable, that means like your symptoms are getting worse and you're having side effects from the treatment, it may not be best for you to sit and continue on therapy. It may be best to go on something else.
The other thing I just want to highlight that's different from chemo, I'd say, is that you get a response, say, 12 weeks after treatment, and then 12 weeks later, the tumor is continuing to shrink, and then another 12 weeks, the tumor may be continuing to shrink. It's not as if there's an optimal response and then that fades away. These responses can continue to occur,
be
months
ongoing and not just be completely front-loaded the way
Exactly.
we tend to see with other agents. Right. What about clinical or histologic parameters, that is the characteristics of the cancer independent of the biomarkers? Are there a group of patients that we can identify prospectively based on whether they're squamous or have adenohistology, or smokers, never smokers? Is there a pattern of patients you can identify in the clinic who you would say are more or less likely to benefit from this class of drugs?
Oh, right now, from a histology standpoint, there doesn't seem to be much of a difference between patients with adenocarcinoma or non-squamous versus squamous cell carcinoma. Early on, it seemed like maybe the patients with squamous cell might do better, but that really has not borne out. However, at least some of the data that's coming out now on smoking status, if you've smoked in the past, you actually may have a higher chance to respond. We're not quite sure what this means. Some people think, at least in smoking-related cancers, you have more carcinogen damage to your cancer, and there's multiple different types of changes or mutations seen that might be more what we call immunogenic or attractive to the immune system, where patients who are never smokers may not have all those changes that may be less attractive to the immune system to attack. But again, that's all pretty preliminary.
Early days.
Yeah.
Well, it seems that at the very least, this class of patients, squamous smokers, who often have been less responsive to some of our more exciting targeted therapies of the last few years, are at least not going to be on the sidelines for this class of drugs. Thus far, we've really only studied immune checkpoint inhibitors in previously treated patients with advanced non-small cell lung cancer. How do you see these agents potentially getting integrated in the overall landscape? Are they likely to be relegated to later treatment, or potentially integrated earlier instead of before chemotherapy for a prospectively identified group? Are they going to potentially be combined with chemo, where you have immunosuppressing chemotherapy potentially combined with immunopromoting or immunotherapy? So there's a lot of ways to potentially combine these. What do you see happening?
All of the above. I think in the end, we will find a subset of patients where this type of therapy would be best by itself. So kind of like the EGFR mutation story for erlotinib, where those patients get erlotinib or afatinib up front. I think we'll be able to find a subset of patients where they will do well with just the immunotherapy checkpoint inhibitor by itself, up front, no chemotherapy. But I think the majority of the patients, we're going to have to figure out how best to combine it with other therapies, to be able to use either those other therapies to help promote the immune response in addition to a checkpoint inhibitor, or use those therapies to combat the cancer itself, to allow the immune system to be able to overwhelm and attack the cancer as well. So we know so little about the immune system, and even how these regular treatments like chemotherapy affect the immune system, or affect how the cancer attracts the immune system. I think we're just seeing the tip of the iceberg, and I don't know if your thoughts as well.
Yeah, and certainly, stage 3 disease, lung cancer, has been an area that's probably hasn't changed much in the last 10, 15 years. And so that seems like a ripe area for, a very fertile area for immune checkpoint inhibitors.
As would early stage patients who have undergone surgery. We've seen some vaccines, and I'll come back to that, but there would be a lot of attraction, I think, or appeal to immune checkpoint inhibitors given post-operatively as a sustained surveillance mechanism with ideally minimal toxicity, compared to at least more feasible than ongoing, more challenging treatments like chemotherapy for more than a few months.
Or you could propose nothing except PD-1 inhibitor.
Yeah, you could.
If especially for patients that aren't fit or able to get surgery.
Or if you identified those patients as the ones most likely to benefit, just like in advanced disease.
Exactly.
What about small cell lung cancer? You talked about areas where we haven't had as much of a change, and small cell has been a challenge for us, where we've really been using the same treatment approaches for a decade or more, with few exceptions. So could this concept apply to small cell lung cancer?
Yes, in principle, it should apply just as well for small cell as other lung cancers, as far as we can expect. But small cell, of course, is a smaller population of lung cancer, and it tends to be pretty aggressive. And so getting patients on clinical trials takes time, and so nonetheless, we do have a couple larger trials opening for small cell patients. There's a trial looking at Yervoy that I believe is just starting to finish in small cell, and the companies are also looking at combining drugs for small cell as well.
Mm-hmm.
Exactly.
What about the combination of Yervoy or ipilimumab with some of these other agents? I know that's looked really attractive in melanoma, but the toxicities could really be a challenge, especially for patients with previously treated advanced lung cancer. Is that something that's being tested now, and is it feasible?
Yeah, at both of our institutions we are doing studies with the combination in lung cancer, and I think it's just too early to tell about how it's going to play out in lung cancer patients, but certainly the hope would be that the combination would increase the response rate and help more patients with lung cancer.
Toxicity thus far is yet to be determined in lung cancer, or looks like it's feasible in the patients you've treated?
I think it's just too soon to tell.
Okay.
So hopefully this year at ASCO we'll have some data.
Okay. Now, we've been talking up to this point just about immune checkpoint inhibitors, and there's been a huge amount of excitement about that. But there have been other immunotherapies in the lung cancer world before these agents, and those have included the MAGE-A3 vaccine, which we should get some data on in this coming year, as well as Stimuvax and Lucanix, which we have seen some data on, and though the larger trials have been technically negative, have had some subsets look good. What do you think about these? Are these going to end up as also-rans, or is there a potentially a place for these other mechanisms to all find a place, or at least some of them to find a place in our armamentarium?
Yeah, and so these vaccines have, if you look at the research, they've always been successful in eliciting antibody responses or immune responses against the tumor. But there was always something in the works that was preventing the vaccine from really creating a tumor response, a tumor regression. And so in hindsight, combining checkpoint inhibitors with vaccines seems like a perfect idea, and maybe some of these vaccine trials would have been more successful if we would have been able to take away those heavy immunosuppressive mechanisms that tumors use.
What do you think about this?
I agree. I think, again, there may be subsets of patients that may benefit from vaccines themselves, and again, figuring out those subsets, and hopefully over the short period of time that we have to get MAGE vaccine study data, maybe we'll find that subset of patients that truly benefit from that, may not need anything else. But I think, again, like we were talking, we're just hitting the tip of the iceberg, and so combining vaccines with other things probably for the majority of patients will be a better answer than just one of each alone.
I'll tell you one thing that's been amazing is that this field has historically been one where it's been slow to get trials completed, but the nivolumab trials and I think many other immune checkpoint inhibitor trials have been remarkably fast accruing. I think the enthusiasm among the enrolling doctors and the patients has been phenomenal. These studies closed very quickly for such large studies.
No, it's been wonderful to see the uptake of this within our patients and their willingness to be part of clinical trials, and I just would say that we want to thank them as well as encourage them to continue help us improve how patients do, because again, checkpoint inhibition, these things by itself may not be the answer for everyone, and we need to do better even than that.
The nivolumab trials completed very quickly, and these are randomized studies with a registration strategy. How soon do you think it might be that we could see the results and even potentially have nivolumab or a related drug available for clinical use? I
think because of how these immunotherapies work, it may take some time to get the information, because we really are looking at what I would say is the tail of the curve. Are we improving patients' survival long term? Not just are we improving the median survival. And so that may take some time to see, and it's hard to say, maybe 1, maybe 2 years. I can't imagine that it would take longer than that.
Well, it's a good point that we're looking partially to move the averages, but if we think that it's going to be a minority of the patients who get a huge benefit, another big issue is a big victory would be finding a 2 and 3 year progression-free survival and overall survival benefit. And we don't know how long that tail is going to be, but that's really an important variable that we're just not used to asking about in lung cancer.
Right, and also looking at the toxicity, comparing it head-to-head with chemotherapy, what is it really like?
Mm-hmm.
And I'm hoping, at least in my experience, it's much less.
Great. Well, thank you to both Drs. Creelan and Dr. Brahmer as well. It's been great. This is really exciting work. Thanks very much.
Thank you.